Okay, all right, so let's get started. Thank you everyone and hello, good morning or good afternoon, depending on where you're joining us from. Welcome to our community of practice of 4 sessions on tobacco use and cancer prevention for people with disabilities. This is presented by the National Center for Health and Public Housing in collaboration with the Disability Network for Tobacco Control and Cancer Prevention. In today's session, we will be focusing on understanding disability in tobacco control. I would like to let everybody know that you can enable the closed captioning, and you can do this by basically turning it on your navigation Zoom toolbar and click the Show Captions button indicated here as the letter A with the yellow arrow. And once the captions are enabled, you can also adjust your settings by selecting the drop-down menu labeled as B with the blue arrow, where you can choose your preferred language, such as English, and access additional caption options. We also encourage you to enable captions if it also enhances your experience in today's learning session. Here we have a few other housekeeping items. All participants are muted upon entry. Please make sure that you also engage in the chat. If you have any questions, please raise your virtual hand if you also would like your line to be unmuted. This meeting is also being recorded, and the slides and the recording link will be sent to you all via email after today's session. And then we also would like to get to know our audience. So please let us know about you in the chat. Let us know your name, what state you're joining us from, your organization name, your title, and what also brings you here today. We will also have we're going to take just a few seconds for some pre-evaluation questions. So you can provide your responses in the poll that will be provided on your screen right now. Hey, Katie, thank you for joining. Okay. All right. Well, thank you everyone for providing your responses. And just a brief introduction about myself. My name is Filipina Sandoval, and I am the Technical Assistance Manager here at the National Center for Health and Public Housing, and I will be moderating for today's session. And with me, I have our wonderful speakers, Katie Stone and Chris Mackey. Would you like to provide your introductions as well?
Hey everybody, my name is Katie Stone. I'm a senior program manager at the National Association of Chronic Disease Directors. And I am the one that works with our disability network. Nice to meet you all. Chris, I'll pass it to you.
Thanks, Katie. Again, my name is Chris Mackey. I am a senior project coordinator with the Lakeshore Foundation in Birmingham, Alabama. I'll talk about what Lakeshore is in a little bit. And we are a partner on the national network with NACDD, providing the bulk of the technical assistance regarding disability inclusion with them.
Thank you. And it's wonderful to have you join us today. Thank you so much. All right, so today, well, basically, these are the overall learning objectives for the community of practice. So we will be focusing on improving knowledge about the intersection of disability, use, and public housing. We'll also focus on identifying and collaborating with disability education and service organizations. And throughout our sessions, we'll also try to apply several strategies to make cessation and prevention programs accessible to people with disabilities. And by the end of the 4 sessions, we'll also try to establish systems for monitoring and sustaining partnerships. So here we have some background information on today's topic. And in this slide, we can basically see an overview of the most recent landscape of functional disability among health center patients by housing type. So in an analysis conducted by NCHPH regarding the prevalence of emotional, physical, and intellectual disabilities reported by health center patients, it was found that there is a significant burden of disability experienced by residents of public housing, HUD-assisted individuals, with both groups experiencing the highest prevalence for 3 out of the 6 study domains, such as disability, immobility, cognition, and self-care, as depicted with the arrows that we have on the screen. And you can see the percentages on the chart that is provided to the right, which has the highest percentages for those 3 domains. So from a tobacco control perspective, this basically tells us that these populations are at an increased risk and may face additional barriers to prevention and smoking cessation services. For example, individuals with cognitive or mobility limitations may have more difficulty accessing cessation programs, navigating healthcare systems, or receiving tailored health education. And in the following slides, we will learn more about how we can understand better disability inclusion and tobacco control.
Okay. Well, thank you, Fide. I will kind of start our presentation. I'll be tag teaming with Katie today. Again, my name is Chris Mackey, Senior Project Coordinator in Community Health at Lakeshore Foundation. And I didn't actually give you a visual description. And so in the spirit of practicing inclusion and inclusion practices, I'm a white male. I'm bald with thin frame rectangular glasses, and I'm wearing a green polo shirt today. And that's just a good practice to be in for individuals who are have vision loss to give a visual description. It's a good courtesy. But today and over the next 3 sessions, Katie and I will be giving you a fairly condensed version of what it means to include people with disabilities into your surface services, with, of course, an emphasis on tobacco cessation programs. And again, Katie and I will be both sharing duties today. Next slide, please. So, as I said, I'm with the Lakeshore Foundation in Birmingham, Alabama. Lakeshore is an Olympic and Paralympic training center that provides opportunities for people with physical disabilities and chronic conditions to live a healthy lifestyle through physical activity and adapted sports programs. But also, we also do research and work in advocacy and health promotion. We are also home to 3 Paralympic sports: USA wheelchair rugby, USA bocce, and USA para powerlifting, excuse me. Through our community health department, where I'm based, we work from a public health approach to build capacity of health promotion providers to, like yourselves, to be more inclusive of the health needs of people with intellectual, sensory, and physical disabilities. Next slide, please. So the reason why we're here today is that we know from data that the CDC provided that just over 28% of adults in the United States have a disability. Um, this amounts to around 70 million people. So as we'll discuss, it's important for public health, healthcare, and health promotion providers to think about people with disabilities as a demographic and not as a health outcome. So this is a very significant portion of the population that often gets overlooked. And it's important that and imperative that public health and healthcare and health promotion organizations pay attention to the issues and needs of people with disabilities. Next slide, please. Data has also shown us for decades now that people with disabilities experience major disparities when compared to their non-disabled peers. In terms of smoking, the CDC has shown that the rate of current cigarette smoking for people with disabilities is more than double, 28%, 20.7%, excuse me, versus 13.4%. Similarly, the percentage of adults with disabilities using e-cigarettes is more than double that of adults without disabilities. And while different surveys sometimes show slightly different numbers, we know that across the board, adults with physical, sensory, and intellectual disabilities use tobacco products way more than their non-disabled peers and experience great health disparities. Next slide, please. So here's the first resource of the day. Um, what does the health of people look like in your state? The link on the slide here, and I'll put it in the chat in just a moment. You can find on this link, you can find data and disparity data, health data and disparity data for your state related to adults with disabilities. And this is from the CDC's Disability and Health Data System. Um, when you go to the page, you'll have a drop-down menu where you can select your state, and it'll say select your state or territory. And so that's what where you can find a number of different health indicators and a lot of data information about your state. So I will put that in a link in the chat right now. And we invite you to peruse that page and tell us in the chat, how does your state look? And feel free to share your reactions to the numbers that you found and the disparities that the data show. Next slide, please. Okay. So in order to understand how to really create any health promotion program that is fully inclusive of people with disabilities, we have to understand different concepts about how people with disabilities and the experience of having a disability is perceived. Um, Here's what I mean by that. Typically, disability is viewed through what is called the medical model of disability. This viewpoint says that disability is a pathology of some kind within a person and therefore a personal problem, and the focus of the medical model of disability is in treating and curing the pathology. So in other words, I have spina bifida, and the medical model says I can't participate in any kind of health promotion program, whether it's smoking cessation or not, because I have spina bifida. That's the medical model, and that's typically how disability is thought about. Next slide, please. In contrast, the social model of disability says that the problem of disability is not within the person, but within society. So when a tobacco cessation program or any other program incorporates universal design and accessibility, that I am able, or a disabled person is able to participate. They are enabled as opposed to disabled. To put another way, the medical model says I can't participate because of my spina bifida. The social model says that I can't participate because the program does not accommodate my different level of functioning. The social model is actually one of the foundational ideas for the disability rights movement and legislation in the United States. Next slide, please. And I'm going to have Katie go through a case study that we have on the screen for today.
Thanks, Chris. Okay, hi everybody. Again, I'm Katie Stone. I'll also do my image description. Thanks, Chris, for reminding me. A white female with light brown blonde hair with a white shirt on, sitting at my desk. So looking at this case study, we're looking at Lena's story. You can all take a moment to read it while I read it out loud. And then I'm going to go through a few prompts. So Lena has a visual impairment and recently received a reminder to schedule a cancer screening. Staying on top of her screenings matters deeply to her. At the clinic, staff had hand Lena several forms and point to where she should sign. The text is too small for her to read. Embarrassed, she quickly asks for help. The waiting room grows silent as a stranger reads her personal medical questions out loud. So, when thinking about this story, thinking about your own clinics, where do you think the problem is? So I'm not going to have raising hands or answering, but just thinking to ourselves, where's the problem here? Is the problem Lena or is the problem the system? Thinking about your clinics that you are serving in, have you experienced something like this before? Has there been a situation where there's a Lena in your clinic trying to access services and potentially cannot, which is resulting in them like not receiving the service or feeling embarrassed about their disability? Fide, I think you need to mute because there's a echo with me and Chris when we're speaking. So thinking about your screenings and your enrollments and your intake, how can we make sure that they are accessible? How can we look at this as a social model and not a medical model? So the social model is saying that the problem is not Lena, the problem is the system. So if there were screen readers or larger fonts, then would there be this issue for Lena? And the answer is no, that Lena would have that access that she needs and she would be able to have the services that she needs and that everybody else has the right to have. So the barrier here is not Lena's vision, it's the system around her. So making sure that when you're thinking about your programming, think about the accessibility and think about how we can remove those barriers for individuals. Next slide, please.
Okay, I'll take over. And so when you're trying to make your services more accessible and really lean towards that social model, using that social model of disability concept, um, it's important to know where your starting point is. In the United States, there are accessibility laws that set a minimum, and I emphasize minimum standard for accessibility. This is the least you have to do. And it doesn't always include, or it doesn't always mean that people have full access. Um, but there are three laws on the screen here that set minimum standards for accessibility, and that includes accessibility of healthcare organizations or services like the ones that you all provide. Three of the most important laws are that relate to including people with disabilities are on the screen, and I'll touch on them in reverse order, actually. The Rehabilitation Act of 1973, particularly Section 504 and 508, require federally funded programs to be accessible to people with disabilities, including healthcare facilities and programs, of course, um, as well as any related information technology, such as websites or the like. And that's covered in Section 508 of the Rehabilitation Act. The Americans with Disabilities Act, which many of you are probably at least have heard of 1990, requires state and local government programs and public accommodations to be accessible, and that includes healthcare organizations. Finally, Section 1557 of the Affordable Care Act also requires that healthcare facilities be accessible and gives special attention. This section gives special attention to information technology access and making websites accessible. All of these laws require accessible environments, accessible services, reasonable modification of policies and procedures, and the provision of effective communication. So it's not just about the brick and mortar built environment, it's about the programming and the services you offer as well. As we'll see in a moment, this can include anything from providing sign language interpreters to providing accessible equipment, easy to read information, or help with transferring onto an exam table, for example. I don't know if that's part of your services, but that's just an example. Um, Not ensuring equal access and compliance with these laws for those with disabilities can and has resulted in programs and facilities having to pay large penalties, or in some cases, patients have died from a lack of accessibility. Next slide, please. So how do we go about creating accessible and welcoming programs for people with disabilities? There is an evidence-informed framework that you can see on the screen here that we have used and developed with colleagues across the country in the disability and health field as an approach for making health promotion programs, including tobacco cessation and cancer prevention services, inclusive of people with disabilities. The framework is called the GRADES, or Guidelines, Recommendations, Adaptations for Including Disability. It's not really important that you remember that acronym, but we want you to know that it is a an evidence-informed framework. There are five domains, and they are the built environment, services, instruction, equipment and technology, and policy. And I'm going to go through each of those and talk a little bit about some of the accessibility and inclusion issues that you and solutions that you would address in the services that you provide. Next slide, please. So the first domain we'll discuss is the built environment, which are structural features built into the facility or landscape. This includes anything from signage, accessible spaces in exam rooms or classrooms if you're doing health education, accessible restrooms, accessible entrances, accessible waiting areas, it's and even parking spaces. Um, all of these details are important for people with disabilities to have access to the services that you provide. Um, and the details do matter when you're talking about accessibility and inclusion. But this is basically kind of mostly the brick and mortar features of a facility that people first think about when they think about accessibility. Next slide, please. Okay, so instruction is the second domain. It is training and education techniques used to enhance learning for staff or for the individual with a disability and or their family members or caregivers. These are things like in-service trainings, webinars, lunch and learns, or other learning opportunities um, to staff, patients, and or caregivers. Topics for providers in particular, and for you all that in the services that you provide can include interacting with people with disabilities, using the National Telecommunication Relay Service, the Americans training on the Americans with Disabilities Act, and other disability rights laws, conducting an accessibility survey with a disability partner, and how to do that, um, and then providing information to support personnel on how to provide information and how to include um, caregivers and a person's support system in their care. So regular instruction actually for program staff and for you all is one way that you can actually sustain a focus on creating accessible and welcoming environments. And you can do that through policy, which I'll talk about in a minute. Next slide, please. So the next domain is services. Services are person-to-person assistance or other assistance that increases participation. This can include understanding the accessible transportation options in your community, and it's not necessarily talking about providing transportation, although of course you can do that, but knowing are being familiar with what's available in your community and how that might affect individuals who don't have their own vehicle or have a hard time using transportation um, is important, and that's one of the services that you would again, not necessarily provide, but understand. Accessible counter marketing, making sure that's accessible to people with disabilities, providing ASL or other interpreter services that might be needed. Again, the law requires that you provide effective communication, then that may be hiring a sign language interpreter service. Uh, Other services could include converting health education materials into alternate formats, such as Braille, large print, which is 18-point font or higher or larger, or maybe an easy read format or a more simplified format. Inclusive imagery and accessibility in smoking cessation campaigns is another example of services, of the services domain. Next slide, please. So the fourth domain is equipment and technology, and by that we mean products or tools used to promote and allow participation. For tobacco cessation and cancer prevention services, this can be things like accessible phone apps and understanding how to um, provide text messages in a more accessible way, accessible exam tables and diagnostic equipment, excuse me, in healthcare settings, and then accessible and easy to use, easy to open medication labeling, and then of course accessible websites. And there are two resources that are important to know if your IT folks want to understand how to make your websites more accessible. And note that one is the Web Content Accessibility Guidelines, and then for federally funded organizations, um, there is, as I mentioned before, Section 508, and they have a website actually, section508.gov, which is where you can go and learn more about accessibility for federally funded programs and websites. Next slide, please. So the final domain is policy, which are laws, rules, regulations, protocols, and procedures designed to guide or influence behavior. And in my opinion, this is arguably one of the more important domains because policy is really what sustains your organization, or what can sustain your organization's focus on inclusion of people with disabilities. Um, so in other words, and I'll talk about it in a minute, do you have formalized policies, organizational policies that include or that focus on the inclusion of people with disabilities? But again, policies can be formal laws. On this slide here, you see big P policy. So that would be things like the Americans with Disabilities Act and the laws that I talked about earlier, such as the Rehab Act. And then there's little p policy, organizational policies such as staff training requirements, or requiring staff to receive training on including people with disabilities. Um, organizational rules or protocols, for example, for obtaining different kind of services like ASL interpretation, American Sign Language, um, enforced organizational policies, and just modifying your organizational structure so that it includes the input and is accessible to people with disabilities. Next slide, please. So some examples of policies that could be implemented and that we would very strongly encourage you to implement in your organizations can include budgeting for accommodations like sign language interpretation. Um, Oftentimes, what we tell folks when we're talking about providing accommodation is that most accommodations cost little or nothing to provide. Um, However, there are things like sign language interpretation that do require financial support and resources. And so it's important to, first of all, have a partner where you can obtain those services, and then budget that into your budgeting process. Bring inclusion into your budgeting process. Um, Other policy and procedure examples: having people with disabilities in advisory or leadership roles. Our next presentation will talk about partnership with the disability community and some ways that you can partner with people with disabilities to make what you do more inclusive. Um, Other examples: policies about how to find different accommodations like interpreters and creating alternate formats. So there's the process of budgeting for that, but then there's also the process of how do you find those kind of services that you might need. Uh, And then, so those are just a few examples of some policies and procedures that you can work towards when you look at promoting inclusion in your services. Um, and if we can go to the next slide, I will turn the rest of the presentation over to Katie and to close us out, and happy to take any questions afterward.
Thanks, Chris. So moving into tobacco specifically, thinking about a tobacco cessation program and really the pillars in a tobacco cessation program, we're thinking about that screening and referral. So very common, you hear ask, advise, refer, or ask, advise, connect, I think is the new one. So you have your patients coming in, you have individuals coming in, you're screening them, you're speaking to them, making sure that we're asking if they use tobacco products, if they have any accessibility needs, is there anything that we can do to make it more accessible for them to be screened and referred? And then looking at implementation. So behavior counseling is an example of a very common implementation for a tobacco cessation program. Thinking about behavior counseling, how can that be more accessible? Thinking about do we want to do telehealth versus text options or in person? Thinking about using plain language and things that are clear to understand and not using jargon. Then thinking about quitting and how we can support individuals with quitting, with medications, um, or other supports. Are there clear instructions? Are the packages easy to open? I definitely know that they are not, because I have a friend that tries to use the gum, and I swear it takes it takes like 20 minutes to open the packet, and by that time, I think he's ready to just use tobacco products again. But like, how can we make that easier? How can we remove that barrier? How can we support those individuals? And then thinking about ongoing support. So how are we following up? How are we checking in with those individuals? So when thinking about tobacco cessation, just having that extra lens to say, okay, how can we make sure that there's no barriers within these pillars so that people can actually access the program and our services? Next slide, please. So here's another scenario. This is with a physical disability. So the scenario is a patient who uses a wheelchair is enrolled in a tobacco cessation counseling program at your clinic. He misses two appointments and eventually stops coming. So thinking about this, I'm sure we've experienced something where a patient stops coming or doesn't, make their appointments. So what are some of the reasons that this patient didn't show up? So thinking in your head. Um, when I read this scenario the first time, I was thinking, maybe the building isn't accessible. So they don't feel comfortable coming into the building. But thinking about it a little bit more, I started to think about transportation for this individual. What does the physical environment around their entire trip look like? Scheduling. What is their experience when they arrive? Is it an easy process, or are there a bunch of barriers in the way? Working at a clinic and seeing individuals with disabilities, what can we do to address these barriers? Could we do for this individual? Um, I'm assuming that we've all seen something like this at your facilities or at your programs. And it is your job and our job to make sure that we remove those barriers. So I think a lot of times you see something and you say, well, the physical environment isn't something I can control. But these are the patients that you're seeing. So thinking about, what are the barriers that you can control and how can we address those? So this is just a reminder that missed appointments are sometimes not about lack of motivation of an individual, but about the barriers that they have that are designed around them. Next slide, please. So Chris talked about the built environment, services, instruction, equipment and technology, and policy. These are all things that are within your control in your organization. Some of them might be leadership's control, but they're all parts of your job. There's a built environment, there are services, all of these are included here. So what are some ways that your organization is already addressing the needs of patients with disabilities? Um, there's definitely some things in place there by law, as Chris mentioned. But what are some opportunities to make the health center more accessible and welcoming to people? So thinking about those things like telehealth versus in person, plain language, and getting rid of the jargon, maybe having two different resources, one that is a little bit easier to understand, having screen readers. So getting familiar with different ways that you can make things more accessible and thinking about the components of your program in those different built environment, equipment, and services domains, and how to make each of them more accessible for people with disabilities. Next slide, please. So the homework here is to identify a few components of your program that you would like to adapt to be more accessible, and start working on those. Even if it's one thing, think about if you've seen some challenges in your clinics, if you've had some moments where it's not accessible and you're really in that medical model thinking, how can you move to a social model? How can you be more accessible? So even jotting something down, like a goal that you have, is really helpful to actually start doing this, start thinking about it, and start implementing. Next slide, please. We do have a lot of resources that you have access to. Um, our organization, NACDD, has a tobacco resource library. It's a digital hub that has lots of resources in relation to tobacco prevention, cancer prevention for people with disabilities. There's general resources, there's health systems, change resources, and insurance, all related to tobacco. Next slide, please. Lakeshore also has resources that you can utilize when thinking about disability inclusion in general, how to adapt programming, and then also you have the ability to listen to some of these webinar series. Next slide. Other resources, and this is from a partner of ours called Accessible Pharmacy. So these are resources that are a lot of times for low vision or blind individuals, but they can be utilized across the board as resources to help with accessibility. Next slide, please. This is just our funding statement. We're funded by the CDC, the Department of Health and Human Services. Next slide, please. And this is your opportunity to ask any questions that you may have. Okay, if you do not have any questions, that's fine. You're more than welcome to email or follow up with Fide, and she can pass along our information or questions that you may have.
Yep. Thank you so much, Katie, and thank you, Chris. So right now, while we wait to see if maybe there are any questions that would like to come in, I'd just like to remind everybody to please complete our post-evaluation questionnaire. We also have provided a direct link to the questionnaire in the chat. If you would like to let us know your feedback, that would be great. It will take about 5 minutes for you to complete. And then also, this is just our disclaimer as well. NCHPH, basically, we focus on strengthening the capacity of federally funded public housing primary care health centers. And as well, we are funded by HRSA, and 100% of the resources are provided by them. And this is just a kind reminder to everyone that our next session will be next week on Thursday, on April the 16th from 1 to 2 p.m. We will be focusing on partnerships with disability-led organizations. And we look forward to seeing you all next week. I don't see any questions in the chat or in the Q&A either. So I think this is it for now. And thank you everyone for joining us, and please don't forget to do your homework. So thank you so much, and I will also be following up with everyone in an email just to send a few reminders.
Thanks,
Thank you,
everyone.
everyone. Thank you, Chris. Thank you, Katie.
Thank you.